Hello, my people. If you remember, when I was talking about bilirubin metabolism, I actually told you that I'll finish that conversation by talking about jaundice. I understand that I've done this video before. However, with this, it will be easier for you to actually understand and be able to roll a conversation with somebody, somebody who understands jaundice deeply. Now, we are not going to talk about the management of jaundice in this, because in the other video I talked about it. I just want to highlight the types of jaundice according to this diagram. So listen to this. We said that the breakdown of red blood cells is the reason why we end up having a buildup of bilirubin in the system. And we said bilirubin is not your enemy. It's a good substance because it indicates the liver function. It indicates it's actually an antioxidant to protect your heart and your blood vessels. And it also binds to toxins to help you excrete them from the system. However, when it starts to build up, that is a challenge, okay? Now, look at it this way. We break down red blood cells, we release hemoglobin, the carrier. The hemoglobin is broken down into two. We have heme and the globin, which is the protein part. The protein part is recycled. The heme part is again broken down into two. We have the iron part, which we recycle, and then we have the bilirubin part, which brings us these issues. So this bilirubin part, the moment it's actually broken down from heme, this is called unconjugated bilirubin. Realize, before the bilirubin goes into the liver, it is still unconjugated. That unconjugated bilirubin is difficult to excrete because it has to be metabolized, conjugated to be made soluble so that it can actually leave the system through urine or through stool. However, at this level, before it goes to the liver, it is still unconjugated and it can actually start piling up. Now, the body carries this through blood into the liver for further metabolism, basically conjugation with the acid that we said is called glucuronic acid. So you conjugate bilirubin so that you come out with conjugated bilirubin. Conjugated bilirubin is more soluble and easy to excrete through stool and through urine. Okay? So the liver is the sole metabolic pathway or metabolic organ for bilirubin. Once you've made it conjugated, it goes through the ducts and out through the gut. Now, this divides you into three phases. Remember, the liver is what we call the hepatic system, okay? So before the liver is what we call pre-hepatic. In the liver, we call that hepatic. After the liver into the gut and out, we call that post-hepatic. So jaundice is classified into these three according to where it actually hails from. Is it before the liver, or in the liver, or after the liver? So pre-hepatic is just before it gets into the liver, which means there is a buildup of unconjugated bilirubin. In the liver, we have a liver problem. Therefore, this liver is struggling to conjugate this bilirubin. So a part of that bilirubin is conjugated, a part is not conjugated because the liver is struggling. So we have a percentage which is conjugated, another percentage is unconjugated, which means you will have both the unconjugated and conjugated bilirubin building up in the system that is hepatic. And then after conjugation, now that we go to post-hepatic, because it has been released into the ducts, is going into the pancreatic duct, into the duodenum and out. So anything that is happening after the liver, from the ducts all the way into the gut and out, that is post-hepatic jaundice. All right. So once you know these three, you know it's easy to classify them. So jaundice is classified into pre-hepatic jaundice, hepatic jaundice, and post-hepatic jaundice. Now, how do we end up getting pre-hepatic jaundice before the liver? We are constantly breaking down red blood cells, both the ones that are deformed, the ones that are premature, and the ones that are actually aging, the older ones. So either we are having hemolysis through due to tropical conditions like malaria, like the fevers, yellow fever and all that, or we are having sickle cell disease. So people who have sickle cell disease, their spleen is actively breaking down the red blood cells, releasing a lot of unconjugated bilirubin, which builds up, of course, that yellow color on the skin and the sclera that is actually yellow, the eye that looks very, very pale and yellowish. All right, and then hemolytic anemia, whether in adults or the one that is in the newborns, all this because of the rhesus factor. All these are conditions that lead to pre-hepatic jaundice. So once you understand that, you simply know this is happening in the spleen and in the blood vessel, in the blood system. That's pre-hepatic jaundice. The next one is now hepatic. We have brought this unconjugated bilirubin into the liver. Now in the liver, we are conjugating it to release it from the system. So now, as we conjugate, let's say we have a liver problem, hepatitis or so. This liver is struggling to conjugate enough or optimal amounts of this bilirubin that is coming in. Therefore, a part of it will be unconjugated because it's struggling, and a part of it will be conjugated because it's actually tried. All right, the liver actually tried, but it's struggling. So we'll have a buildup of both conjugated and unconjugated bilirubin. That is how we know it is actually hepatic jaundice. Right? So that is stage number 2. So therefore, any tumor in the liver, any problem in terms of alcoholism, people who are more alcoholic, they have a fatty liver, an alcoholic fatty liver. People who consume a lot of fructose and the sugars and the processed foods, they're causing a lot of inflammation in the liver. They're actually going to experience hepatic jaundice, sometimes pre-hepatic, but mostly hepatic jaundice. Okay, people who are constantly abusing paracetamol, right? There are these people who take paracetamol every single day, whether it's Maramoja, Panadol Advance, or Panadol Extra, or Maramoja, whichever it is, whichever brand of paracetamol you're taking, you are abusing it daily, and paracetamol is one of the drugs that is actually well known to cause hepatitis, right? So when you're taking that paracetamol, be very cautious. That's why you should take it for about 3 days, and if the pain persists, you should seek medical advice, because pain is a symptom. You cannot focus on treating the pain and then end up killing the liver, and now you have jaundice, and that will be a double tragedy, because you have to clear the jaundice and at the same time help you recover from the hepatitis that is caused by paracetamol. Some antibiotics like gentamicin that you use for a long period of time in terms of resistant brucellosis, right? This is actually going to cause you problems. The reserved antibiotics like the chloramphenicals, like the vancomycins, and the spectrinomycins can actually destroy the liver, and anti-cancer medications. So these are the reasons why, including viral hepatitis, hepatitis A, B, C, all those. These are the conditions that actually affect the liver, causing you hepatic jaundice. Number 3 is the post-hepatic jaundice. Now, anything beyond the liver, anything after the liver. So whether we have a blockade in these ducts, the hepatic ducts, whether we have a blockade in the gallbladder, whether you have a blockade in the biliary duct or the bile duct, whether you have a blockade in the pancreatic ducts, all those will start causing a buildup in conjugated bilirubin. Remember, you are beyond the pre-hepatic because you've broken it down. You have now conjugated in the liver because the liver has no problem, but you have a problem in terms of occlusion. So you either have the cancers of the gallbladder, you have cancer of the pancreas, you have an inflamed gut, or you have just an occlusion of these biliary ducts, which is causing the buildup of conjugated bilirubin that gets to overflow and backflow into the blood, causing you post-hepatic jaundice. So tumors that are basically liver, gallbladder, and pancreatic, you have gallstones that actually block the gallbladder, and these stones can actually be released into the ducts, blocking the ducts, therefore building up the bilirubin. We have the gut mess, because remember we said gut microorganisms are very important in terms of finishing the process. They convert the urobilinogen into stacobilin to release it in stool, and then some of the urobilinogen is reabsorbed back into the liver, goes into the urine, and is excreted, and some of it is used to form bile. So if you have a problem with the liver, you can imagine how far you're going to suffer with this. If you have a problem with the gut, you can imagine. If your population of gut microorganisms are a mess, you can imagine. That's why we say always constantly fix the gut, because apparently when you're fixing the gut, you're also fixing the liver, right? You're fixing your spleen, you're fixing the entire system. So it's very important for you to fix the gut, and most medical conditions hail from a messed up gut, which means the sooner you fix the gut, the better it becomes for you. But the more you want to fix the symptoms, for example, if you have, let's say, hepatitis, or you have a fatty liver that is coming from fructose consumption, and then you go and take medications for the liver, you see, you're not fixing the problem, because fructose is coming in from the gut and from the diet. So you change the diet, you help the liver to recover. This is an organ that can actually recover so fast. So you help it recover, and within 14 days to 30 days, you have your liver back in order. So please, constantly keep fixing the gut. Now, there's a syndrome that is actually called Gilbert syndrome. Now, when you hear the word syndrome, it means a collection of diseases. However, Gilbert syndrome, some of you might end up having this as a diagnosis. When you have jaundice, you see the doctor writing the diagnosis as Gilbert syndrome. What does that mean? It's actually jaundice. But this is because your liver enzymes that are supposed to help you conjugate bilirubin are actually defective. So the genes that controls the enzymes that metabolize bilirubin, that conjugate bilirubin, are actually messed up, which means you're ending up with a backflow of unconjugated bilirubin into the system, All right. So most times you might think it is the liver problem. Of course, it's a liver problem because the enzymes are coming in from the liver. But you might think it's just hepatitis or a fatty liver or issues with the liver basically. And yet, it's an issue with the genes, the genetic modification of the enzymes that are actually supposed to help you conjugate bilirubin for you to actually excrete it from the system. So this is what we call the Gilbert syndrome. And these are very, very common word when it comes to diagnosis of jaundice. So you might see this if you have jaundice, or you might see just a diagnosis of jaundice, both of which are actually telling you you're having issues with a buildup of bilirubin. Okay, so I think this lays now a background for you to discuss jaundice, and you can combine that with the information I gave in the previous video about jaundice.